Hi, everybody. My name is Dan Tryman, and I'm the CEO of New England Israel Business Council, or NEIBC for short. NEIBC is a not-for-profit organization that its mission is to strengthen and facilitate the business relationship between Israel, New England in general, but in particular, Massachusetts and the Boston area. In the last few years, we have seen quite a big growth in companies that are contacting us regarding healthcare and how to do business in Massachusetts in general. And this actually drove us to develop this three-part webinar, which the first webinar you're going to listen today, the introduction to the US healthcare system. We are planning to have the second webinar on May 16 at 10 a.m., which will be called US Regulatory Affairs Best of Practices. And the third one will deal with reimbursement. It will be on June 6th. What I would like to do is also thank Sagit Sadeatia, my partner in crime, in putting this webinar together, this series together. Sagit will manage the questions that we are going to have during the presentation. And at the end, David Baron will be available for Q&A. And with that, I would like to introduce David today. David is a principal and co-founder of Boston MedTech Advisors, BMTA for short. He has over 35 years experience in the healthcare industry, including management, technical operations, strategic planning, marketing, and business development. Currently, as part of BMTA, he focuses his activities on advising, and assisting U.S. offshore medical technology organization ranging from startups to Fortune 500 in areas ranging from opportunity analysis, marketing strategy, market development, reimbursement strategies, business development, and financing. Prior to co-founding BMTA, David held senior management positions in medical device companies and has founded, financed, and developed a number of healthcare companies. He holds a graduate degree of biomedical engineering and MBA from Rensselaer Polytechnic Institute in New York. And with that, David, the podium is yours.
Thank you very much, Dan. I appreciate the opportunity and looking forward to a discussion. I'm going to start sharing my screen. Thank you again, Dan. So the formal title is Introduction to the US Healthcare System, but the more important title is noting that the US market is the largest, which implies it has the biggest opportunity for manufacturers of medical technologies, but it's also the most complex market, which implies that in order to realize the opportunity, people need to really understand this market. Just a few words about Boston MedTech Advisors. We are in business almost for 20 years. We worked with about 400 companies worldwide. About less than half are US-based. The rest are Israeli, Europeans, and Asian companies. We cover, over the years, almost every space in healthcare. And the important thing is to, when one talks about BMTA, is to realize that we really have two focus points. One is to support companies to introduce new technologies, to work with them until they introduce the product to the market. And the other one is to help increase the likelihood that the technology would be eventually adopted. And in order to do this, we really have to deal with all the areas that you see on the right side and other ones, because it's really a puzzle. In order to develop adoption, one needs to be involved and understand how all the pieces fit together into a singular puzzle or picture. The agenda today, we don't have a lot of time, and the topic is very broad. So I'm going to touch on a number of points. First, just talk a little bit about what are the business realities and create the context to really why it's important to understand the US market. Then talk about US healthcare system, really 101 and a fairly rudimentary level. Talk a little bit about who pays for everything that is done in the United States. Explain why the current system cannot continue like it is today. Talk a little bit about what are the changes that are underway. What is the take-home message for us, for developers of medical technologies or services for this market? If we have time, I'll touch on a couple of case studies and try to leave a few minutes for questions and answers. So I'll move quickly. So the first slide, I always start the presentations with this slide and try to establish the realities. Everyone that ever developed a business plan has something similar to the blue line. Shows that at a certain point of time, they introduce the product to the market, and after a period of time, they start seeing some scaling and getting some market adoption of the product. The reality is that the vast majority of the products really follow the green line. That's true for startups, and it's true also for large companies that are developing new technologies. Most of the products, 90% of the products that reach the market after they've been developed and got the approval to be on the market, really never gain market adoption. They remain very episodic. It's only a small subset of the products, the red lines, that eventually reach adoption. It's a small component, it's a small fraction of the products, and it generally takes them longer than what they thought originally. Why is that? There is a paradox here. On one hand, we need new technologies to support all the increased requirements and needs, but it is more difficult to gain clinical and market adoption, even though those technologies are needed. And in a very simplistic overview, what transpired over the years, you can see here that 20, 30 years ago, it was relatively easy to gain adoption. Products that demonstrated safety and efficacy and some clinical evidence were able to be on the market, get the FDA approval, and very quickly, most of them gain adoption. If we do fast forward to today, safety and efficacy are still required to gain FDA approval, although the requirements are greater today and it takes longer and requires more time and money. But there are many other requirements that have been added before product is being adopted in the marketplace. And adoption means subset of the market is using the product on a regular basis. We need much more clinical evidence, including much more outcome data. We need to deal with the reimbursement of the economics. It's much more important than it used to be. It was really a non-issue until the mid-late 90s. And there are new requirements that are being added all the time, like comparative assessments, for example. It's not enough just to demonstrate that the product is working and it's being reimbursed. We need to demonstrate that how this product or service or method are stacked against alternative interventions. So what we are seeing, there are more barriers for adoption. Things take longer. Fewer companies make it, and there are implications for this. Revenues are being delayed. We need more funding rounds to support the activities, which are now taking much longer before we can see cash flow coming from sales. Valuations are negatively impacted in the earlier stages. Business development initiatives are delayed. Companies and major players are sitting on the sideline until the product is showing some initial adoption. And in the process, we have greater risks that other things will happen, like additional competition and so on. Moore, those that are familiar with the Moore curve, recognize this chart. It's really most companies are focusing on the early adopters. They don't realize that before they can move into the main market, there is a chasm. There are other things that need to be addressed in order to overcome the gap. Since most companies don't realize what is that chasm, or they realize but don't prepare themselves appropriately to overcome this chasm, they really get stuck with the early adopters, always the episodic revenues, and never make it into major adoption. So moving into the American healthcare system, it's really a patchwork of different arrangements and is very confusing to navigate. It's not my words, it's really taken from a book that was written by Ezekiel Emanuel, who was one of the architects of the Obamacare about 12 years ago, in a book which is highly recommended, where he compares the US healthcare system to other healthcare systems in the world. So to sell medical products or services in the US, it's a must to understand the healthcare system. And what does it mean to understand? We need to determine what is the clinical application that we are offering, really be able to be very specific about that application. We need to understand what healthcare system we are targeting, because there are lots of different systems and each one operates differently. Who would be the providers that will use a product or service, and who will eventually pay for those things? And in order to determine those things, there are many considerations that have to be addressed. What is a specific clinical need or clinical utility of this product or service? What is the workflow and how our product is going to affect the current workflow? What is the economics? And who is going to pay for this? Who is going to be the beneficiary? Who is going to be willing to cover something that may be more expensive? What is the legal and regulatory environment? And they change from one healthcare settings to another settings and from one system to another system. Who are the decision makers? And that changes, depends on which healthcare system you're dealing with. What are the specific barriers? And more and more. So after that encouraging or depressing introduction, just touching on the US healthcare system. There are lots of elements describing the healthcare systems. You can divide it into three major categories: community-based care, and there are lots of players involved in this, all the way from home, physician offices, centers, everything that is done before a patient has to be hospitalized. Then there is acute care hospitals. We're generally familiar with those entities. And then there are all the services that are provided once a patient is being discharged from the hospital. It could be rehab, it could be nursing facilities, it could be outpatient services at that stage, it could be home care. And this is only a partial list, really, of all the elements. Who are the players in this market? It's actually, healthcare is the largest industry in the United States. There are anywhere between 7 to 10 million people, depends on which source you're looking at, of individuals that are direct participants in this market. Physicians and surgeons, it's obviously the core of the system. There are about 700,000, although some charts will show close to 1 million. Nurses, about 4 million when you look at all the level of nursing. And then you have therapists, technicians, diagnostic specialists, pharmacists, and support personnel. So it's a big industry, lots and lots of people involved. Let's just try to take a little view on the settings. Outpatient settings first. Physician offices, there are close to 1 billion visits a year. Less than half are with primary care physicians, the rest are with specialists. Emergency department, close to 150 million visits a year. About 15% of them are in teaching institutions. Those are the big names that we hear. But the vast majority are non-teaching institutions, non-teaching hospitals, hospital outpatient visits. And there are lots of types of visits, all the way from clinic visits, general medicine, where we go to an outpatient clinic, and it goes all the way to surgeries, day surgeries. And then there are many other ambulatory care settings, and this is really a partial list. And again, it's a hodgepodge of many different settings. Each one is doing different things, playing a different role. You have ambulatory surgery centers that are essentially providing services that are similar to what hospitals are providing. You have clinics, government-owned, government-operated or funded, or private. You have retail pharmacies that are now providing clinical services, lots of walk-in clinics. It's a new trend. They are providing an alternative to either a physician office or to an emergency department visit. Then you have workplace clinics, schools. Telehealth is a big element that is growing, home visits, and so on. The inpatient acute care is really built around 6,000 hospitals in the United States, close to 1 million beds, active beds. Every single day, there are about 500,000 people that are being hospitalized in the United States. Overall, in a year, there are 30 to 40 million admissions. So those are big numbers, where the average stay per patient is about 5 days. Obviously, many are staying more, some are staying less. Less than 10% of the population is hospitalized each year in the United States, about 9%. But the hospital are consuming about over 30% of the national health expenditures. The vast majority of hospitals are what we call community hospitals. They are not owned by the government, they are owned by communities or by corporations. About 2/3 of them are in metropolitan areas or suburbs, and about 1/3 are in rural areas. Those are generally small communities, very small hospitals, but they play a very important role. About 20% of all the hospitals are teaching institutions, which means they are affiliated with medical schools, or they're providing training for graduates of medical schools. But those teaching hospitals are generally larger, and they provide 50% of all the services that are being provided in the United States. We have for-profit hospitals, not-for-profit, for-profit. The not-for-profit about 3,000, the for-profit about 1,300 hospitals. They're much smaller. They tend to be smaller hospitals. The not-for-profit tend to be the larger ones. You can see it in the number of beds. The trend towards for-profit has been slowed a little bit. It was moving very rapidly in the 90s and early 2000s. State and local governments own about 20% of the hospitals. And then you have a whole hodgepodge of other hospitals. You have hospitals that are owned by the federal government, like the VA and the Department of Defense hospitals. There are psychiatric, non-federal, and there are lots of other ones. And then, as I said before, there's a long-term care post-hospital. Again, it's a huge industry, very diverse, close to 100,000 different facilities across the United States that serve almost 10 million people on an ongoing basis. Those are people that are staying in those facilities for long periods. You have adult day services. You see the numbers here. Home health agencies, those are typically nurses or technologists coming, or therapists coming to patients' home and providing services. There are 12,000 facilities or agencies that are taking care of about 4 to 5 million patients every year. Hospice, nursing homes is a big industry. There are over 1 million residents that are living in nursing homes. And then there are assisted living facilities, about 30,000 around the United States, with, again, close to 1 million residents living in them. So who pays for all of those things? So there are really 3 primary categories. This is as the simplest illustration of the healthcare coverage in the United States. The reality is that it's much, much more complex than what we're seeing here. But the 3 primary pockets of funding are Medicare, which is a federal program, covers everyone over the age of 65 years old, about 50 million of those 50 million lives. But it also covers about 9 million of permanently disabled, younger than 65 years old. It's about 18% of the population, 40% of the Medicare lives or Medicare beneficiaries are now covered by commercial programs through Medicare Advantage programs. Then we have the Medicaid, which the Medicare is by and large, it's a federal program and it's intended to support the elderly in the United States. Medicaid is intended to address the needs of the healthcare of the lower income individuals in the United States. There are 50 Medicaid agencies. Every state in the United States is running its own Medicaid program. There's also a children's program, children that are not covered by parents' insurance. Overall, Medicaid covers, it's now about 27, 28% of the population. And then we have all those that are not covered by Medicare and Medicaid, covered by commercial, private insurance, although there are about 10% of the people that don't have any insurance in the United States. Most of the commercial or the private insurance is covered or is organized through employers, as we all know, but also a lot of individuals can purchase their own insurance if they are not covered through their workplace. Just diving one level below this, Medicare receives funding from the government, from taxes, from employers, from employees directly, employees' contribution. Even those that are covered by Medicare, many of them still have to pay some premium for outpatient services to cover some of the outpatient services in Part D, which are medications. And Medicare then, through its contractors, is paying all the providers of services. It could be hospitals, could be physician services, pharmaceuticals, as well as what's called Part C, which is a Medicare Advantage. They pay commercial payers to provide coverage for individuals that are entitled for Medicare benefits. Medicaid is funded jointly by the federal government that covers about 70% of all Medicaid expenses, and about 30% is covered by the states. It's important to know that Medicaid is the single largest cost item for every state in the United States. So it's a big issue for everyone. Medicaid could be, there are different plans of Medicaid. There are certain elements that are consistent along all Medicaids that are required by the federal government to provide certain services. But in principle, at the end of the day, each state has a different set of benefits and different plans, different cost structure, and so on. And again, similar to Medicare, they pay all the different providers of services once they get the money. And then we have the private insurance. As I mentioned before, it's paid for through employers. Generally speaking, about 70 to 75% of all the premiums are paid by employers, and the rest is paid directly by employees through their contribution. And the insurance companies, there are hundreds of them throughout the United States, they pay all the different providers. And that's somewhat of a different point, but since we're talking to primarily here in the webinar to people that develop medical technologies, how do manufacturers of medical technology get money here? In most cases, they don't get it directly from the payers, unlike provider of services. Manufacturers are selling the products to different providers. It could be hospitals, physician offices, nursing facilities, and so on, directly or through distributors. It's those providers that are submitting the claims, requesting money from the insurance companies. They're submitting the claims, they're getting payments, and that payment has to satisfy their own expenses, as well as a cost of the distributors and the manufacturers. So the payment has to cover all the chain looking backwards. National healthcare expenditures. This is a chart that you can see only in the United States, the growth of the expenditures. Actually, from 1970, over the last 50 years, the cost of healthcare expenditures in United States have grown 70-folds. We are spending about $4.5 trillion every year in the United States versus $75 billion 50 years ago. The growth is just out of line with any other country in the world. It translates on the average to over $13,000 per person in the United States. And you can see on the right side, I'm not going to go through all of this, who is getting all this money. Obviously, about a third goes to hospitals, professional services, physician services, clinics. They're about a quarter, and then you have a list of everything else. This is an interesting chart. I mentioned before that on the average in the United States, we spend $13,000 for every individual, but this is an average. And just like any statistics, it could be very misleading. The reality is that if we take 50% of the population, they are responsible for about 3% of all the expenditures in the United States. If we look on the right side, on the 5% of the population that are most expensive, this 5% is responsible for 50% of the expenditures. And actually, if we look at the 1%, top 1% of the people, they are responsible to 20% of total healthcare expenditures in the United States. So the chart, the expenditures are very non-linear. And obviously, everyone is interested in understanding how to improve what's being done in the top 5 or 10%. So the current situation cannot continue. Why it cannot continue? If we look at this chart, what is the impact or what is the weight of this national health expenditures as a percent of GDP in the United States? You see that it has grown from about 8% about 50 years ago to about 18% today, and it's projected to grow. It has a list on the right who pays for those things, but that's less important. At the end of the day, the people, we all pay for those healthcare expenditures. And healthcare expenditures is the single largest cost element today for every employer in the United States, other than wages. And it's actually becoming the most important cost element for a lot of individuals. These expenditures, you can see here on the left, the chart comparing what's happening in the United States to the rest of the OECD. The average OECD country spends about 9%. In the US, it's twice as much. And as you can see, there is a big difference between the United States and the other countries. Switzerland and Germany are the most expensive countries in terms of healthcare outside the United States, and they spend about 11 to 12%. So it's about 2/3 of what United States is spending. And it's not that we get better care because of this. There's obviously a lot of waste, a lot of cost elements that have to be dealt with. For those people that are from Israel, Israel, by the way, spends about 7.5%. So they spend in Israel, they spend less than half of what the United States is spending as a percent of GDP. And some of the characteristics that are contributing to this out of whack chart. In the United States, unlike any other OECD countries, there is no single national government that is paying or operating the healthcare system or controlling it in one fashion or another. There is no single payer system. Not every country has a single payer. The United States obviously doesn't have. It's very decentralized healthcare system with a mix of private and government organizations that are providing, paying, and setting policy for healthcare. So it's really a big mix. As I said in the initial slide, it's a very complex landscape. Numerous sources of funding flowing from multiple private and public entities to pay for healthcare services. You know, the charts that I showed before, Medicare, Medicaid, there is no comparative charts in any other country in the world. It's unique to the United States. There are private organizations of providers and payers, including both not-for-profit and for-profit entities. And we see, especially in the last 10 years, more not-for-profit insurance companies that are converting to for-profit. So it's not only that they're providing important services, people realize that there is a lot of money that could be made here in the process when you spend 18% of GDP on healthcare. What are the growth drivers to this increase from 75 billion to $4.5 trillion? Most people think that the primary contributor is life expectancy that has increased and the aging of the population. As you can see in this chart, it's actually a smaller contributor. It's not the biggest one. It's less than 1% of the growth year over year. Has to do with the aging. It's really the two primary contributors are the utilization of technology. We're using more and more services all the time, and everyone can reflect it on himself or his family, and the intensity of those services. Just as an example, if 20 years ago, most of the imaging were done using X-ray, today we're using CTs and MRIs. They are much more expensive. So we're doing more scanning, and we're doing it with more expensive, more sophisticated and more expensive technologies. And the prices keep growing. There is inflation, inherent inflation in the prices. Products are getting more expensive, medications are getting more expensive, services are getting more expensive, hospitals are charging more money, and so on. So overall, healthcare costs are out of control. There are very different profiles at any other sector of the industry. You see here over a little bit more than 10 years ago, the data is a little bit, the information over 20 years ago, over a period of 20 years, the healthcare inflation, the healthcare cost almost doubled compared to everything else that we are seeing. We're speaking a lot about inflation in food prices. They've grown about 50%, about half of what healthcare has grown. In many other sectors, actually, the cost per unit has gone down considerably over a period of time. The lower chart shows that this is not just an impact on the government, but we all feel it personally. Over a 10-year period, the inflation, the overall inflation that, not including the last year, obviously, was about 17%. Average earnings of workers in the United States increased by 26%, but the out-of-pocket expenses, mostly the deductibles, but also the co-pays and items that are uninsured, increased tenfold for earnings during the time. So when you have that picture, that cannot continue forever. And changes are underway. And the major change that is happening really got a big push through the so-called Obamacare Affordable Care Act about 12 years ago, is an attempt to shift the whole incentive of the industry from volume-based, incentivize all the providers that exist to provide more services, because more services imply more money, is to moving towards something that is a little bit more amorphic, called value-based. So historical current payment structures really suggested do more or incentivize to doing more with no incentive for efficiency, whether it's a fee for service that we are all familiar with, or fixed price like DRGs paying hospitals. There are a few other methods of payments, but those are the two primary ones. There is no incentive to reduce cost, overall expenditures. There were attempts, and there are systems that are working on capitation. Capitation in principle suggests do less, or incentivize people to do less, but there is no incentive for quality. And when there is no incentive for quality, there's plenty of data that shows that in the end of the day, the cost of care is more expensive if we don't do the right things. So a statement by CMS a few years ago, they stated, we are moving to a system that rewards value over volume. Paying for value will foster innovation as providers look for ways to compete by providing the highest quality care at the lowest cost. So what is value? Value is measured by patients' health outcomes per dollar spent. We generally can understand what is a cost. It's much more difficult to assess or to measure quality. So different organizations, different systems are developing different methods of measuring qualities. And this is just an example. You don't use the same quality measures for every service. It depends on the settings, depends on the system, depends on the type of services, depends on type of patients. But the idea is that everything that is being done, there'll be some ways of measuring the quality. And even if those measures are far from perfect, they are much better than not measuring anything. And that process of that thinking is leading to many initiatives. Some of them are more advanced than other ones. And you may have heard some of this alphabet soups, accountable care organizations. And we don't have time to go to all of them. Each one of the lines here is a presentation, can be a presentation by itself. Value-based purchasing programs, reduced payments for hospital-acquired conditions, hospital readmission reduction program, or no payments for readmissions, different risk-sharing arrangements between insurance companies and providers, and it goes on and on. So the new landscape that is emerging, it's still by and large in the United States, a fee-for-service system. But most providers, most healthcare systems, most constituencies already understand that the system is likely to change. And when they think about what is that they need to do tomorrow, they're thinking more and more about this value-based system. The incentives are very different, as I said before. We're going from fee for every individual service or component of service to bundle care, paying for whole episodes of cares rather than for every element of the service. Payers assume more and more financial risks. And again, for manufacturers of devices, years ago, physicians, surgeons were really the key influencers or decision makers as to what technologies they want to use. Now, those days are actually over, and every decision for new technology, new method, new practice is becoming a group or a healthcare system decision. So what is a take-home message for us? Us manufacturers of technologies or new services. When should we start identifying our target market? What is it that we want to do? The success of a company is predicated upon demonstration of market adoption of the technology, or at the minimum, convincing investors early on, partners and acquirers, that we are on the track to gain adoption. Everyone wants to know what we are doing beyond what we are planning to do to create a market beyond getting FDA approval, which is obviously a necessary step. Adoption requires a comprehensive understanding of the target market. You cannot expect to get any adoption or to be successful without having in-depth understanding of the market that you are pursuing. In defining the optimal market, once you can do it, it enables the development of a coherent strategy, which defines a product, regulatory roadmap, clinical studies, clinical evidence that need to be generated, and your marketing go-to-market strategy and the business model. A lot of people are still, we're saying it again and again, starting with product configuration, developing a product, chasing FDA approval, do one study, and then they go to the market without having a strategy. They're actually doing things around, the other way. And again, just to summarize maybe the take-home message, in the past, years ago, 20 years ago, not dealing with this roadmap beyond regulatory approval was not a big deal, because most of the products that reached the market after FDA were adopted. There are very few market barrier to adoption. In the more recent past, not dealing with those things was bad practice, but it wasn't terrible. And today, companies that are not understanding the roadmap all the way to adoption early on, it's really business malpractice. So the sooner, we're often being asked, when should we start looking into those things, into understanding the market or developing marketing strategy or understanding reimbursement, all the things, or what other studies we need to do, or which market we should pursue. We'll do it later on. People are asking me, when should we really start doing it? And the answer is very simple. The sooner the better. It really should be done from day one. I'm just going to touch on a couple of case studies that we're involved with. Both happen to be companies that started in Israel, but their activities are primarily in the US. One is a company called Itamar Medical. It's a publicly traded, both case studies are publicly traded, so I'm not disclosing anything that people don't know or cannot find. They developed a home-based technology to study sleep disorders, specifically sleep apnea, for different reasons. The legacy markets, the establishment, sleep medicine field was objecting to this technology for different reasons, clinical arguments, but strong consideration was concern that physicians involved are going to lose the income that they generated. And that led to a situation that sales were nominal. The market was pretty much close to the company. So looking at what the company could do, how they can reach the market, we recommended to commercialize the product, to focus initially on healthcare systems that are not dependent on reimbursement from third-party insurance plans, like government-run VA system, like Kaiser Permanente, so-called integrated delivery network, which is both an insurer and a provider. And that strategy was very successful. Those, 90% of the marketing effort was directed at those systems initially, and those systems really adopted in a big way the technology. And with that adoption, we approached CMS, Medicare, and convinced them to issue coverage even before we had CPT codes, because we couldn't get CPT codes because of the objection of the industry. Medicare, after a process, developed a national policy that included coverage, and subsequent to this, all the other elements of the market open up. And as a result of this, sales have started to increase. Once the company reached last year about $50 million in annual sales, with very nice growth, because now the market is open for them, growing about 30% per year. About a year and a half ago, they were acquired by the Boston-based Zoll Medical for about $500 million. Another example, another case study, a company called NovaCure. NovaCure developed a technology for treating solid-state tumors using electrical field, very, very different technology. It's a continuous technology that is delivered for patients in an ambulatory setting at home all the time. The first approval that they received a number of years ago was for one of the smaller cancers, for glioblastoma, although now they're in the process of applying for other applications, larger applications. Company wanted us to develop pricing rationale for this technology, which is very different than anything else. But more important than the pricing was, what is the reimbursement structure for the treatment? And that review of the reimbursement structure actually led us to recommend to the company to become their own provider. So it's not a very common strategy, but it's one of the options for company rather than sell the technology to hospitals or to clinics and so on, to cancer centers. They are the provider of the technology. They deal directly with the patients. They deal directly with the insurance companies. Company received a code for this technology, and now they are receiving in United States over $10,000 per patient per month. Patients are using this technology from the moment they start. Today could be very close after they've been diagnosed with a cancer, brain cancer, all the way through the rest of their life in most cases. Even though it's a very small cancer compared to the more common ones, the more prevalent ones, the revenues exceeding $500 million, and the valuation now is about $7-8 billion. So I tried to rush, I apologize, but I'm open for questions.
Thank you so much, David and Dan. I only see 2 questions right now. There was a request to receive the presentation if possible. People that signed up. And the second question is from Christina, asking, where is there greatest adoption and momentum around value-based care?
So we're seeing it more in teaching institutions. We're seeing it in different pockets around the country where they're getting into different payment structures. With Medicare, for example, Medicare is a big driver of this value care, and they are initiating what they call demo programs. Say every time they have a different structure that they want to try or they want to institute, they'll work through a subset of the market and offer it. And a lot of those new payment models they're based on value payments. So they require manufacturers to measure the outcomes. There is no specific place that you go and see who, we're dealing with value, we're structured based on value. It's really across the market. But generally, you see it more in hospitals that with individual clinicians with primary care, for example. You're seeing it in entities that are part of accountable care organizations. So again, it depends. If the right answer is to understand what is a product and what is a service, and then deal with it and say, in that, for this market, for this application, these are the people that are subject to value-based payments or value-based models.
Thanks. There's another question from Jim, from Amir Luzon. What is your working model with very early stage startups?
Amir, the best way is to contact me after the meeting. I don't want to get into business issues at this point. It depends. It really depends. We are trying to adapt the model, the way we're working, to the needs of the company, to what is it that we are doing. So we're very flexible when it comes to those things.
Sure, I'll drop your email at the end. There's another question from Jim. What is the present situation of healthcare inequities in the United States, and how is the market dealing with it? And what is the impact of government policies on the U.S. healthcare market based on the current challenges the market face due to increase in healthcare expenditure? That's a big question about inequities and how the government and market can deal with that.
So equity in healthcare, or inequity in healthcare, is a huge issue. It's very political. And again, the market is too diverse to provide overly simplistic question. There are different elements to this. There are shifts in budgets. that are available. There are federal programs and state programs to deal with the uninsured, with the illegal individuals living in the United States and still need to get health care. Every hospital in the United States is required by law to treat people that have poor insurance or no insurance. They're actually required to treat them exactly the same way they're treating people that are insured. There are systems that are developing their own policies as to equality. There are, you find it in physician levels. There are physicians, just as an example, that unless if there is a new medication or a new device that is being offered to them, unless they can offer it to everybody, they're not going to offer it to some people. They want to know that they can provide equal care to everybody and not distinguish it based on their insurance. So there are lots of elements into this. The important thing is that there is greater sensitivity to those issues and greater visibility to those issues.
Thank you, David. Two last questions. So I'm gonna mention the questions and you can take them at the order you want, David. The first question is from Ron Rabitsky. User experience and interoperability have risen to formidable barriers to adoption. What is your perspective? The second question is about the use of the use of AI and its implication in medical field. And then I'm going to drop your email so people could reach out to you for direct questions.
So the first question, the whole information system that is being mandated a little bit about 10 years ago on all providers. So on one level, there is greater information sharing within systems, and there are greater barriers between systems. So we think again, a bipolar system or implications that have, or situations that have bipolar implications. But in principle, every new technology that is being introduced today, every service has to figure out how they connect to this IT systems in one fashion or another. The days where somebody can introduce a system that doesn't connect or doesn't provide information sharing, those days are over. As far as the AI, everyone assumes that there'll be huge revolutions associated with AI. We are starting to see it on the margins really now in healthcare. There are areas where there's AI being introduced, AI-based products being introduced. For example, helping radiologists. There are many companies that are providing AI tools, AI-based tools to help radiologists gain better efficiencies or do a better job by identifying things that may be difficult to identify without AI on images. We see many companies, huge number of companies developing AI products that are looking at a hodgepodge of medical records and trying to extract information in a coherent and succinct fashion so physicians can provide, again, make better decisions with that information, because no one is able to really review all the information that is today available on any one of us. There are a lot of people trying to debate the role of artificial intelligence on physicians, whether artificial intelligence will one day replace some of the specialists. We really don't know, and it's too dangerous to say never. There have been a lot of predictions that haven't worked, and there are a lot of predictions that did work in the past. So it's dangerous to bet against technology. But we know that in healthcare, adoption takes time. As I said before, there are many barriers, including for AI. And AI in healthcare probably will lag behind many other industries. It will happen, but initially on a slow base. Even in radiology, which is probably the area where we have seen most AI activity today, there are lots of companies, lots of solutions being offered, but the adoption is still very slow in the marketplace for different reasons.
David, thank you very, very much for this impressive presentation, overwhelming, for me at least, unbelievable. It's much appreciated. With that, have a great rest of the day for everybody.
All the best.
Thank
All
you.
the best.
Thanks, Dan, and thanks, Sergey, for organizing this.
Thank you both,
Thank you.
Dan, David, everyone for joining. See you next webinar.